Good afternoon. I'm Beth Badalino, President and CEO of Healthy Women, the leading national not-for-profit women's health organization whose core mission is to help women make informed decisions about their health care by providing relevant, evidence-based, medically vetted information and resources that meets women where she is in her life. And we've been doing so for more than 30 years. Women find us when they are looking for answers, and they leave us feeling more informed and more empowered. Today, I am so pleased to kick off our briefing in hopes that it will be the catalyst for change. In partnership with the Black Women's Health Imperative, we have launched the Reclaim Your Wellness campaign in an effort to change the dialogue of obesity to one that is free of stigma, free of judgment, and free of bias. We provide educational resources, share real women's stories, and offer informative conversations with experts. I encourage all of you to explore our campaign site with the link in the chat or visit reclaimyourwellness.org. As part of the campaign, we are excited to bring to you this briefing today entitled Intersections of Weight, Stigma, Mental Wellbeing, and Health Disparities, Considerations for Policymakers, and to learn more from our esteemed panel of experts. Before we start the presentation, I want to thank Novo Nordisk for their support of our campaign and for this briefing. Now, I am so pleased to introduce our moderator for today's briefing, WUSA 9's weeknight anchor, Leslie Foster. Leslie has spent nearly 2 decades working to earn the trust and the respect of viewers in the greater Washington, D.C. area in her role as a journalist, an advocate, and first informer. Known for her warmth and ability to share reaching stories, Leslie thrives on the work that touches everyday living. That journey has allowed her to interview many local, national, and international luminaries. But she most enjoys talking with ordinary people, using their lives to do extraordinary things. Leslie, thank you again for joining us. And now I will hand off the program to you.
Beth, thank you so much. I'm excited to be here and always delighted to be in community with Healthy Women and the Black Women's Health Imperative for this journey. Reclaim your wellness. What better opportunity to really kind of bring people together around this idea of wellness and wholeness and happiness. And certainly as a Black woman, as a mom, as a journalist with a platform, I think it's really important that we have these kind of courageous conversations about stigma around weight in our society and really work to provide a more welcoming and embracing society. One of the things that I have learned on this journey is about changing the love language we use in which to talk about this journey and ensuring that people, wherever they are in the circumference of their experience, maintain their personhood. So we're going to talk about people living with obesity, and we're going to talk about the things that we can all learn about this journey and hopefully perhaps even give lawmakers some considerations to think about as we continue this journey. So with that said, I'm going to kick off this conversation with our esteemed panelists this afternoon, and we begin with Dr. Janet Tomiyama. She is a professor of psychology at UCLA, where she leads the Dieting, Stress, and DISH Lab. Her research is focused on the harmful health consequences of stress, of dieting, and of fat shaming. She's received numerous awards for her research, and she's received wide media coverage. She is a graduate of Cornell University and UCLA, and she is the one among us on this panel who is on California time. So while we're saying good afternoon to all of you, we are saying good morning to Dr. Tomiyama, and please take it away.
Thank you so much, Leslie. Thank you also, Beth. I'm so pleased to be here today to share a little bit about my research on weight stigma. and mental health. And so I want to start here. So as you all know, as congressional staff, there's a widespread culture right now that perpetuates and kind of thrives on fat shaming. So some famous examples, celebrity Jillian Michaels saying really mean things about Lizzo, pervasive fat shaming across social media and also conventional media as well. And so, what I want to talk about today is very prevalent weight stigma, a scientific term I'll be using to capture the fat shaming, negative attitudes directed at heavier people, the discrimination that they face. And if you look at nationally representative data, fully 42% of the US population reports experiencing weight stigma. If you look at heavier folks, the number jumps all the way up to 70%. And so that's really staggering. That's well over 100 million Americans who are dealing with this stigma in their everyday lives. And so, people might think weight stigma actually a good thing, because it maybe motivates people to eat healthier and exercise more. And so over the past decade plus, I've been really researching this question of weight stigma. Is it a good thing or is it a bad thing? And I can tell you after that decade of research that the answer unequivocally is no, it's not motivating. And in fact, it really destroys both physical and mental health. So weight stigma actually backfires. So weight stigma causes increased eating, not decreased eating, due to stress-induced eating and comfort eating processes. It also causes sedentary behavior. So if someone's been mean to you because of your size, the last thing you want to do is put on some Lululemon and go to the gym, which is, a context where people are constantly fat shamed. Weight stigma also predicts future obesity, no matter what you weigh. So it's not just that, heavy people get heavier. It's across the BMI spectrum, no matter what you weigh when you start out. If you experience weight stigma, you're at future risk for obesity. And then on the topic of what we're talking today, weight stigma predicts poor mental health. So here's a statistic for you. We know from nationally representative data that people who experience weight discrimination are 2.5 times more likely to have mood or anxiety disorders. So that's depression, bipolar, and anxiety. And the point I really want to hammer home is it's not just a so-called fat people problem. It's not just that heavier people are experiencing this across all the body mass index. So no matter whether you're on the skinny end or the heavy end, it doesn't matter. If you experience weight stigma, then you see these negative mental and physical health outcomes. And so those are some factoids and statistics, but I also wanted to kind of give you a sense of how do we study weight stigma scientifically. And I wanted to give you a glimpse into my lab and one of the studies that we've done. So this was a study called The Psychology of Shopping. It sounds, really fun to be a part of. It was actually not a fun study to be a part of, but let me walk you through it as if you were a participant. So you sign up for this study, you come into our suite of lab rooms, there's a door that's kind of halfway open, and you can see through that doorway that there's a bunch of clothes, and pop music is really blaring out of this room. And we said, okay, we're doing a study on shopping in groups and hormonal responses to that. And we're really lucky. We had an up and coming designer donate the clothes for this study. But first we need to make sure you'll fit into the clothes. And so we're going to take you over here. We're going to put you on the scale. We're going to weigh you. And then we have them wait in a waiting room with a very thin person. They're actually part of our study. They're actually a secret study staff person, but the participant doesn't know that. And so we beckon to the thin person and say, great news, you've been accepted into the shopping activity. You can go in and start shopping with everyone. And then we turn to our participant and say, unfortunately, your shape and size just aren't ideal for this style of clothing. We really do want everyone to have fun and feel good. And plus we want to return the clothing to the designer in good condition. Now, if I were giving this presentation in an actual room in a live setting, normally you'd hear some gasps and whispering across the audience. But one point I want to make is that often the heavier women in the audience say, this happens to me every day. It's not something you should be so shocked about. Welcome to my life. And we have some data from other studies showing that this kind of stigma does happen. And then we measure their cortisol levels. And I'll talk in a little bit why cortisol is important. But basically, we have the no stigma control group on the left, the stigma group on the right, and then cortisol on the y-axis. You don't need to, understand the specifics of this graph, just know the conclusion, which is that stigmatized participants have higher cortisol than control participants. So it's not just that weight stigma makes someone feel bad, it actually creates physiological changes in their body. And these changes are not the kind of changes you want, because we know that cortisol signals your body to deposit fat, especially in the belly region. So it actually drives future weight gain, ironically. And we know that cortisol is a major risk factor for all sorts of mental disorders. And so I just want to leave you with the take-home message that weight stigma is not good. It actually harms the health, both physical and mental, of Americans. And I'll put my contact info up here. Oops, it didn't show up, but you have it here. And I'm happy to take, one question right now.
You'd think by now, after all these Zoom meetings and sessions, we'd be familiar with the mute and the unmute button. Some of us are a little slower than others. Apologies. Really quick, though, and thank you for that insightful information and the real world application of how you find these things out, and just a window into the kind of feedback that you receive. I have to ask you, I hear a lot of people talking about weight gain during this pandemic, and I certainly can count myself among those folks. But I wonder, has your research changed because of this pandemic, because of COVID-19? Do you find that the weight talk and the weight shaming is either more or less prevalent because we've been in this situation for, the better part of almost 2 years?
Yeah, such a good question. And I would say absolutely. So, people talked about the COVID-15 that people gained while in quarantine. And so a lot of people have kind of engaged in fat shaming and also internalized and fat shamed themselves. The place where I saw the greatest amount of weight stigma was actually in response to the initial vaccinations, where individuals with obesity were, among the first to be vaccinated. And we saw a lot of vitriol against heavier individuals saying, why do they get to skip the line? It's their fault that they got the way they are, and just like really vicious fat shaming, in the context of this really scary mortality threat that is COVID. So I think, if anything, everything just kind of intensified.
I want to ask you one more question, because you talked about weight shaming and how that can occur regardless of where you are on the scale, right? Regardless of whether someone might perceive you as being overweight or living with obesity, wherever this is. What I'm hearing you say is that weight shaming can happen regardless of who you are. And you talked about that self-talk that some of us give ourselves. How do we weight shame ourselves, and how can we take that out of our vernacular? How can we change the way that we talk to ourselves about who we are?
Yeah, it's so difficult when the culture is so pervasively discriminating and stigmatizing against heavier bodies. Weight is such an interesting area because exactly of what you said, of this internalization. So you don't see this kind of negative self-talk in other stigmatized identities. So for example, I'm Asian and I actually like Asians. I'm a woman and I like women, but heavier individuals tend to really internalize that self-directed fat talk. And so it's a really tricky question. There are, of course, therapeutic approaches, but we really also need to focus on the broader kind of societal, cultural, policy level, which is why I'm so happy to be here today talking to you all.
Well, I want to thank you for your contributions to this conversation, because it's really, really important. And it sort of moves us into our next speaker, who is Dr. Natasha Burke, who is a professor of psychology at Fordham University. And Dr. Burke's research program really starts to make some inroads into eating and weight-related disparities by addressing measurement and models and interventions for multiply marginalized children, which is an interesting term. And I'm sure Dr. Burke will get into that a bit. adolescents and also adults. And what she uses and utilizes is really this intersectionality informed approach to examine the ways in which one's multiple social identities interact to inform their risk for eating and weight-related pathology. And we're going to get into a sampling of that today. Dr. Burke, as we build on this conversation, the floor is yours now. Thank you.
Great, thank you so much. I'm very glad to be here today speaking with you all. So as Dr. Tomiyama mentioned, weight stigma negatively affects both mental and physical health and is more demoralizing and demotivating than anything else. It's certainly not a helpful thing. So problematically, even those in the healthcare professions engage in weight stigma, and this significantly impacts patient care for those in larger bodies. So this healthcare provider bias has really serious consequences. Providers readily ascribe negative attributes to patients based on their weight, and this provides a lower quality of care. So indeed, healthcare providers are much less likely to spend time with patients at the higher end of the weight spectrum, yet are more likely to order costly extra tests and recommend additional procedures for those individuals. Now, ironically, tests and procedures and recommendations that might actually be needed may not be provided due to weight stigma. So as just one example, research suggests that when presenting for treatment of lower back pain, that those in larger bodies had their accounts of pain discounted so that they're judged as their pain is judged as less intense, less interfering, more exaggerated, and less attributable to medical factors, and judged as less in need of treatment. And so therefore, receiving less treatment and related work accommodations than those in smaller bodies. And so research suggests that this disproportionate treatment is in part due to these negative attributions and discriminatory actions that healthcare providers have towards those in larger bodies. And this also contributes to health disparities. So this is also compounded by the focus on kind of downstream health promotion tactics that are really focused on individual behavior change, which really negates the strong and driving influence of biological, social, economic, and environmental factors at play. And so the focus on, that individual versus the broader social determinants of health is common, but really short-sighted. And there are several upstream factors that influence health. This is from Healthy People 2030, and just shows that the multiple aspects of health that are related to social determinants include healthcare access and quality, which I just talked about how that can be influenced by weight stigma, neighborhood and the built environment. And by the built environment, I mean human-made surroundings that provide the setting for human activity. So you can think about green spaces and parks. Recreational buildings or lack thereof, social community context, economic stability as well, and education and access and quality. And so focusing on the individual, which perpetuates weight stigma versus the broader social determinants of health, really leads to disparities in healthcare and disparities in quality of care for those in larger bodies. But it's really important to consider this in the context of intersectionality. So what is intersectionality? It investigates how intersecting power relations influence social relations across diverse societies, as well as individual experiences in everyday life. And so as an analytic tool, intersectionality views categories of race, class, gender, sexuality, nation, ability, ethnicity, and age, among others. And in that among others, I would put weight status as interrelated and mutually shaping one another. And so that intersectionality is a way of understanding and explaining complexity in the world and in people and in human experiences. And so if we consider kind of multiple identities as interrelated and shaping each other, including both how we see ourselves and how others see us, we consider disparities in weight status among communities of color and within communities of lower economic resources. We can see how compounding that with disparities in diagnosis, disparities in treatment based on weight status can really lead to multiple avenues of risk for communities of color and those of lower socioeconomic status. So as really eloquently stated by the National Institute of Minority Health and Health Disparities, there are many populations in the US that are already experiencing high rates of certain diseases and more deaths and suffering from them compared with the general population. And while the diversity of the American population is certainly one of our nation's greatest assets, one of its greatest challenges is reducing the profound disparity in health status of its racial and ethnic minority, rural, low income, and other underserved populations. And so the intersection of identities of those of socially and historically marginalized communities, along with more often being in bigger bodies and experiencing weight stigma for those communities, further contributes to health disparities for those in those particular communities. And so we can consider how the identities that we hold, they carry different levels of power and privilege. And these myriad identities have different levels of kind of social, economic, political power and privilege, or lack thereof. And though certainly weight stigma is harmful to all it's directed towards, there are particular groups for whom the intersection of weight stigma with historically marginalized social identities likely results in even greater disparities in healthcare.
Another great presentation, Dr. Burke, and you gave us so much to talk about. I must say, we've talked long about, outside of this circle, about the health disparities that plague this nation, but it is quite a different thing to see it sort of in black and white and gray and color when you talk about the various things that are occurring as a result of the disparities and the healthcare provider bias, which is really something that we need to pay a lot of attention to. I want to talk to you because there's a question that came in that I think might be particularly suited to you. And the question is, so we are working to remove weight bias from education materials in a WIC clinic, right? Which is women, infants, and children. What recommendations do you have for removing such terms as obese and overweight? And I sort of alluded to this a little bit in my introduction to all of you, because a lot of times the terms that are used to describe someone's lived experience take away their personhood, right? So we've learned to call people obese instead of saying they're living with obesity, which acknowledges the whole of the person. So I wonder, given these marginalized populations that you talk about with multiple identifiers, which make them even more susceptible to this kind of bias, how do we address that?
Yeah, that's a really great question. I think it has to be start at the beginning when we're educating healthcare providers in terms of what are some of the words that are more helpful for folks and less helpful for folks. And certainly using words, there's been studies showing that using words like obese is really not helpful for individuals. And that instead focusing on what are people doing to focusing on behaviors, just general behaviors that would, we would ascribe to any individual, in terms of, are they getting adequate sleep? Are they getting adequate activity in their lives? Are they getting a balance of different kind of nutritional aspects in their lives? Focusing on those behaviors versus a number on the scale or versus certain words that we're using is really more important. And I think if we can focus on those broader aspects, then we can better care for those, particularly for folks who are, have less economic resources. So we know that food insecurity is paradoxically kind of related to, people having larger bodies. And that's in large part, there's a lot of reasons for that, but particularly, we think about what is cheaper and easier to access. And there's a lot of really calorically dense, but nutritionally poor foods. And so I think if we think about the environment that people are in and kind of what they're bringing to the table versus just a number on the scale, I think is a way to kind of address that.
Really quickly, to address this most specific question, it sounds like what you're suggesting is the folks who are running this particular clinic who are working on removing that weight bias have to be very intentional about the words that are chosen, perhaps even saying, okay, we're changing this today and this is how.
Yes. Yeah. And using those terms is, there's been research saying they're not effective, and can be a turn off to people. And when we're trying to engage people in care generally, it's really important that we're working with patients kind of where they are. And so I think eliminating some of that wording that is really more technical medical jargon can be helpful.
That's really impactful. Thank you so much, Dr. Burke, for that information. Our next panelist is Patty Neese. She serves as the chair of the Obesity Action Coalition. It's a 75,000 member nonprofit organization that represents the interests of people both affected with and living with obesity. Patty is a passionate advocate for people affected by obesity, and she works to ensure patient access to and coverage of science-based obesity treatments and the eradication of weight-based bias and stigma. She is encouraging change by sharing her own journey. And in her professional life, Patty is an attorney for the U.S. Department of Labor. We are delighted to welcome Patty. And Patty, the time is yours now.
Thank you, Leslie. I am so pleased to be here with this just outstanding group of women. I am honored, honestly, and I'm happy to share with you today some of my own experiences, particularly with weight bias and stigma. I don't remember a time when I wasn't carrying excess weight. I've had obesity since I was a child. It's not a choice. I was always an active child. I remember when I got my 10-speed bike, it was this beautiful cream color, the hint of green, it had the curved handlebars. That was how I got around in this world. I was on swim teams, I did gymnastics, you name it. Yet I always carried extra weight. And my obesity grew more severe as I grew older and moved into adulthood. And throughout that time, because I had excess weight, it exposed me to essentially a lifetime of ridicule and bullying, simply because of my biology and because of my size. Weight bias and stigma comes in 1,000,001 different cuts. It's everywhere in our society. It's ubiquitous. It starts young. Your peers tease you. Fatty Patty was a rhyme that my peers liked. But it's not just your peers when you're young. It's also things like the school nurse weighing you in front of everyone in the class and then turning around and saying, you're fat, you need to lose weight. At a time when all you want to do is fit in. That's what you want to do as a kid, right? Yet here was this person of authority not singling me out because I had straight A's or because I had perfect attendance, singling me out because of my weight in front of all my peers. And it really never stops. High school, dating a guy who stopped dating me because his friends teased him about going out with the fat girl. Walking down the sidewalk, people in cars, just anonymous people yelling out things like shamu or moo, just because I'm walking down the sidewalk. They don't know me. They don't know anything about me. Or not being assigned in a work situation a special assignment because they're afraid my health may interfere with it and my ability to carry out the assignment when that had never happened before in my life, because I've been very successful as an attorney. Being curb qualified, shopping for a car, people not willing to help me because they don't think I am worthy of their time. They don't think that I am going to be able to buy that car that I'm looking for. I don't know why, but that's what they think. Going into a store like a Saks Fifth Avenue, nobody being willing to help you or talk to you. because they've ruled you out as a potential customer because of your weight. And then there's the medical community. And certainly Dr. Burke mentioned those, and it is true. I can't tell you how many doctors have told me you need to lose weight, but not offered any help in that. No support. And here's how you do it, sort of thing. I also can't tell you how many times I've been misdiagnosed because of my weight. The worst was an orthopedist who didn't even let me describe my symptoms to him, said I needed to lose weight. I was experiencing back and hip pain. He didn't examine me. He asked me if I considered weight loss surgery. He ended up berating me about my weight and said, diagnosed me with obesity pain. Instead of recognizing that I had a 60-degree curve in my spine and progressive scoliosis that was degenerating. Totally missed it because he couldn't look past my weight. It's just one example of the thousands I could give you of problems in the medical community. And all the time you're told your weight is your fault. Dr. Tomiyanama talked about internalized weight bias. That's what happened to me. I became my own worst bully because I believed everything people were saying to me. That I was weak-willed, even though I'd managed to have a successful career, that I was a failure, that I wasn't worthy, that I was less than. And I had to overcome a lot of that before I could even begin to manage my weight. And I also knew after trying diet after diet that there was something stopping me. Something was there, but I didn't know exactly what that was until I found professionals who actually know how to help people with obesity. An obesity medicine specialist and his team helped me learn more about obesity as the health condition it is, as the disease it is. It is complex and we are not totally in control of our weight. We just aren't. Different life stages can create different conditions in your body, the control weight, and different mental conditions. You know, I got to the point after being shamed and blamed and ridiculed for so long that I withdrew. And as Dr. Tomiyama suggested, I ate more. My life got very small. And I had low self-esteem and felt rotten to my core. And I had to learn how to overcome all of that before I could speak about any of this to anyone. I also have had a very privileged life, and I cannot imagine adding and layering on other stigmas like Dr. Burke mentioned. You know, take race, for example. I can't imagine how much more difficult that would be. And it's nothing we think about. We overlook it. We overlook it. So those are just a few of my experiences and what happened to me personally as a result of weight bias.
You know, Patty, I appreciate the courage that you've brought with you today. And it takes quite a bit to share your personal story in front of people you know, let alone people that you don't know. But I suspect that part of the reason why you're doing this is because you want to make life better for other people, right?
Absolutely
That's why
right.
we're all here, to
Right.
make someone's life a little bit easier on the journey. You've been an advocate for a very long time. We're talking about living with obesity in different ways, kind of. And so I wonder if there's some encouraging change that you've witnessed that you want to see folks build on as we try to move this further along.
I think there are two things that I find very encouraging. One is our most recent research shows that very direct weight bias, like the people driving by in the car and yelling at me, has gone down. But by the same token, intrinsic weight bias, what people really feel about people of size, has actually gotten a little worse. But I'm encouraged that there's at least some movement, and I think there's more understanding coming to the field. The other thing that I find very encouraging is the development of new treatments for obesity. Even though I should have good health insurance as a federal employee, I mean, it's okay, but it doesn't cover anti-obesity medications. And it places huge restrictions on things like bariatric surgery and what you have to do to qualify for it. So we need to move past those. And I am encouraged by movement in Congress to pass something called the Treat and Reduce Obesity Act, which would cover additional treatments for people on Medicare for their obesity. So those are, I think, good developments overall.
Patty, again, thank you again for sharing your story and for your courage. And sometimes it takes hearing it from someone who maybe you haven't thought about the role you may have played in touching someone's life with your own words and actions, but hearing you say with great clarity about how it cuts to the soul of who you are, right? This is what I think people need to hear sometimes to make change. And you mentioned bariatric surgery, and our final speaker today is Dr. Nina Crowley, who is a bariatric surgery dietitian and a health psychologist working as a program coordinator at the Metabolic and Bariatric Surgery Program at the Medical University of South Carolina. I just want to say, Dr. Crowley, that's a whole lot of words to put on a card. And if you're able to do that, that's pretty remarkable. I know you are a passionate advocate for policy, and you serve as a leader with the Obesity Action Coalition. So you certainly know about the work that Patty and others are doing. You're also in that coalition with the Academy of Nutrition and Dietetics. You're also with the American Society for the Metabolic and Bariatric Surgery, which is called ASMBS. So you come with a lot of bona fides to talk about this next layer of our conversation. And so I'd really like you to weigh in. I think Patty teed this up in a really personal way. She talked about no one talked to her about that next level of trying to live more healthily with obesity. No one said to her, here's how we can help. And while bariatric surgery has come up for a lot of people on the journey, my late stepfather ended up having bariatric surgery as well. So I know a bit about the journey to get there and how difficult that was for him and for many families across the country. So can we talk a little bit about this and what you maybe can help us do to unpack the impact of weight stigma?
Yeah, thank you so much for having me today. This is an important panel, and Patty and I go to lots of conferences together. She's one of my favorites to sit next to when we are listening to speakers. So I'm definitely missing out on some of our together time. But I do also want to thank the organizers too for having a patient voice here. I mean, we have heard a lot, I'm sure in your world, about manels or or panels without females on them. But even in the healthcare community, we do see a lot of panels talking about patients without them there. So I know that's something I'm very passionate about, is they're part of the solution, and you can really miss the mark when you're not including the people that you're trying to help in that conversation from the beginning. So I'm glad to have that, be the format here. So what I'm going to talk a little bit about, I want to kind of move to what can we do next kind of a place for those who are on the call today, and in particular share how some of that weight bias or weight stigma impacts the policies that we have that are supposed to help people who have the disease of obesity. So next slide. As you've heard today, weight stigma does have a strong negative impact on our mental well-being, and it worsens some of the health disparities that you've heard today. So what I'm going to share is a little bit more about how some of these negative attitudes that so many people hold about people with the disease of obesity actually can influence our policies that really should be helping someone with a chronic disease. So in my experience, I've been working with patients who've had surgical treatment for obesity for about 15 years. And I'm both really entrenched, enmeshed maybe, and also discouraged by how the policies are written for people to access care. In particular with surgical or bariatric surgery, there's a statistic we hear a lot that only 1 to 2% of people who qualify for surgery actually end up having that surgery. And I would argue that it's not because 98% do not want help losing weight or they're not interested in a treatment option. Many of our payers have additional higher copays or deductibles specifically for surgical weight loss treatment, and they don't have those for other procedures. So you would never have this kind of higher level deductible for something like cancer treatment or high blood pressure. As you get more advanced in the disease, the treatments ramp up and they're covered. So in my own state, in South Carolina, where I live, our state employee health plan is one of the past, or one of the last, I think 2 or 3 that are left with blanket exclusions for treatment for obesity. So no room for the doctor to weigh in, to give their, medical opinion, clinical judgment. It's an exclusion off the bat. There's other policies, of course, commercial policies similarly, where it doesn't matter what your health condition is, you are not a candidate because you have this health insurance. So that really cuts that off right at the beginning. And so for people who are referred who don't have that coverage, it's just crazy. There's also things like it's my word, illogical conditions or comorbid conditions that are required for someone to have access. This is true with medications as well. So they pick kind of an arbitrary body mass index. And if it's below, 40, you might have to have reflux or high blood pressure or diabetes, but not always the same for all the insurance companies. So it is really hard for my staff to figure out, what is the policy, what makes someone qualify? And really, I'm coming back to why. Why are those the conditions that they pick? Is that based in evidence? Certainly, there's a lot more evidence about which conditions can benefit from weight loss that's not outlined on those policies. Also, I think the assumption that in all areas, people can see specialists. So, that's based in bias. Payers can have decided that someone, maybe needs they mandate these weight loss efforts with a certain provider. So maybe even dietitians, they might not live in all of the rural areas where people who have this condition live. And so if that's a requirement of accessing the treatment, that's a specialist that they can't see. So they're not available everywhere. They might not be able to leave work or their family or commute that far to get to someone, limits on telehealth or limits on their schedule. And then they have some policies that limit seeing more than one provider in the same day. So they might also require that you see a dietitian 6 times before surgery, but some won't even reimburse those visits. So there's all kind of levels. I think Patty said layering on some of these, levels of bias when it comes to these policies. And again, they're not based on evidence. It's an assumption that people who are seeking, in my world, bariatric surgery should have to meet some sort of benchmark prior to being allowed to get the next level of treatment. I've also, kind of joked with my team about this, but some of these policies literally require an advanced degree or legal background to figure out. And so I know that is not what I went to school for, is to decipher an 80-page document that should be patient language. So, and not naming names, but some of the criteria for some of these policies are added with, specific criteria about no net weight gain, air quotes I can use because you can see me, no net weight gain over 6 months, or a specific calorie level for X amount of weeks before they're approved. I think they're kind of ludicrous, because you're saying the person can't lose weight by any of these other methods and they need surgery. But if they gain weight during the time they're working to get there, they're not a candidate. So I could go on that one for a little bit longer. But back to sort of the bias, most of these plans also do require non-surgical attempts at weight loss. And I think, again, that makes common sense to most people. Like, yeah, you should, work with someone as you're working towards surgery, make sure your habits are on track. And yeah, of course, behaviorally, we do want to work towards that. But requiring that someone arbitrarily meet with someone for a certain number of visits, assumes that they've not done that recently. And at the time where someone is seeking surgery, just like you said, Leslie, he ended up having surgery. There's also that bias that like, that is the end of the line, the last ditch effort, they've tried everything else. And yet the research tells us that earlier intervention, getting to someone sooner in their disease state, really is the thing that helps improve post-op outcomes. So there's just a lot of that embedded in the policy. And I think, timelines, limits on future treatments, once per lifetime, policies and all of that can make it really complicated. So on the next slide, to kind of move forward, I wanted to talk a little bit about, beyond some of these barriers, how can we remove them and how can we actually increase access to care instead of limit it? So the good news is that nutrition and behavior therapy can really help so many more conditions than we currently have access to. So, rather than placing limits on the conditions like only if they have diabetes with a certain blood glucose level or chronic kidney disease, which are, the limits within Medicare right now, better policies will allow practitioners to use their clinical judgment about which patients this therapy would be best served for those conditions. So for prediabetes, obesity, high blood pressure, cardiovascular disease, those are disproportionately affecting some of our minority communities. We really would benefit from an expanded definition of what conditions could be served with something like medical nutrition therapy or obesity treatment options. And then, as I said before, rural and medically underserved areas, they often rely on their advanced practice providers, their PAs, their nurse practitioners to help treat patients, and specialists like even dietitians in some areas are not as widely available. So the policies that specifically allow only an MD, only a primary care to both treat or even refer patients are also kind of putting undue limits on the care for people in those areas. And then I also would say, something that we've all seen in the past couple of years or the past, 2 years, that the traditional healthcare model that we knew required people being in person, it's not necessarily the only effective way. So as a dietitian, my colleagues and I work in a variety of places, but requiring that we work within a primary care office, like the current intensive behavioral therapy requires, is sort of weird. We don't work in those offices. I mean, I'd love to have dietitians employed in those areas, but requiring that and then that not being where people work is, again, another limit of just, layering on limits to access to care. So the policies that we even have are not fully utilized because of some of these barriers. And, finally here, the variety of services. So intensive behavioral therapy, which I'll talk a second about in a minute, and nutrition counseling, medications, surgical interventions, it's all sort of on a spectrum, right? Just like you would have with blood pressure, one medication, two medications, right? You add on as they are experiencing success or not with their outcome to that medication. That's what you would want to do in this treatment realm as well. So, some policies covering one or two or not all of the options. Again, these are all barriers to, someone being able to consistently access care and not letting the medical team optimize care. So burnout would be a whole nother talk, but it's pretty disheartening for providers who see a patient who they could help with a treatment that's available and having their insurance be the limiting factor. So on the next slide, the two policies I wanted to share, for the folks here today is that, these are things that we think can help address the barriers and increase access to care. I work all day long talking to patients who can't understand why it makes sense for insurance to cover 17 medications, a CPAP machine, and constant visits to the doctor. That makes common sense. I feel the same way about this. How does this, this makes common sense, right? We know that there's conditions that can be helped with nutrition counseling and therapy. We know that the primary care providers are both in limited supply, time crunched, and not trained in the areas to really help people with that. As Patty mentioned, they're not even giving her the most basic of, advice about how to access, what to do for her. So this act, the MNT Act, expands the list of conditions. So, there's all sorts of other things other than diabetes and chronic kidney disease that someone could benefit from nutrition counseling. And not just as an added benefit, we're talking more like real evidence to support clinically effective treatment here. And I think most people can agree that both, nutrition therapy and counseling is also cost effective. I wish maybe we made more money and it wasn't as cost effective, but that's a whole nother that's a whole nother ask. But it is cost effective, it's clinically effective, and the variety of conditions really can be expanded for that benefit. We also want to be able to allow some of these non-physician providers who really know their patients the best to be able to even do that referral. So the MNT Act, I think, is something I'd hope everybody could really sign on to and see some impact with the conditions that we can treat, both from underserved area medically, economically, and all of that as well. And then the other policy that I wanted to share is, hopefully you've heard of this before. I know I've been talking about it for 10 years, the Treat and Reduce Obesity Act. It'd be nice to talk about something new. So if you can all help me out and make that happen, I'd be excited. But the Treat and Reduce Obesity Act is really removing barriers. So needing to see that primary care provider in a primary care setting, allowing other providers beyond the primary care provider to deliver the care. So whether that be dietitians, behavioral health, and other advanced practice providers, allowing them to be reimbursed for their treatment as well. It'll also be a much needed update for some of the FDA approved weight loss medications, or anti-obesity medications, as we call them. There was nothing available. When I did my training, it was like, there's fen-phen back in the, olden days. And like, there was this real big gap between that and what was next. And so, we don't have time to go through what all of those are, but that's the good news. There's lots, and they're not just a one, give one to anybody kind of a medication. It's really targeted to that individual's specific, behavioral and genetic profile. And so this bill would also authorize coverage for those medications. And I do think it's important to say that it complements intensive behavioral therapy. So that's about 26 visits a year as directed by the BRFSS, which I can never say properly. They recommend at least 26 visits a year. This is in addition to that. So you're not just adding a medication without the counseling and the, all of the other stuff that goes along with it. So again, I think this is something that really shows interdisciplinary care. It shows efficacy, cost effectiveness, and it really would help to see a difference for our Medicare beneficiaries, and hopefully other, payers would follow. So hopefully that gives you something to kind of wrap your arms around as far as, something that you can do. And I'm happy to answer any questions if we have time left.
Dr. Crowley, thank you again also for your significant contributions to this conversation today, as we're all talking about working to end weight stigma and weight bias and have more of an embrace of weight inclusive care. So let's round this out with a lightning round here with a little bit of time that we have. Patty, I want to give you the last word, because I feel like sometimes, as Dr. Crowley said, we miss the opportunity to have people who are on the journey to really make that closing statement. So I'm going to save you for last, but Dr. Crowley, since you just finished, we'll have you go ahead and give a quick response to this. And then I'll have Dr. Burke and Dr. Tamiyama. The lightning question is, what's the one takeaway that you want all these people who've joined us today to take with them? Dr. Crowley, you first.
Oh gosh. Well, sign on to these bills. Get your bosses to do that. If that's our audience, that's the real takeaway. But really listen to people with the disease. And I mean, it's not a minority. Most of us have this disorder. So look around and help the people that you're working and living with, and really, get back to that place of compassion and do the right thing.
Thank you, Dr. Crowley. Dr. Burke? One last takeaway?
Yeah, thank you. I think my last takeaway is that weight stigma is not helpful, and it is harmful, and it affects people from aspects of their patient care, their family relationships, their school relationships, their work relationships. And if we really want to see more equity in the U.S. in a variety of populations, then working to increase some of those the factors related to social determinants of health versus individual factors is a way that I think we should move forward.
Dr. Tamiyama?
Yeah, I just want to say it's easy to see weight as a simply health related issue, but I also like to think of it as a social justice issue. So, what does it mean that we as a society are treating people as less than because of the way they look? Wasn't okay with racism, it's not okay with sexism, so it's also not okay here with body size.
Really important points to make. And of course, Patty, you have the final word or words.
Thank you. We have the power to change this, both in our individual lives and in our policy choices that are made. We have the power to start looking for when people are being made fun of or ridiculed or whatever in our own lives and saying that's not appropriate. Standing up to people, actually seeing weight bias in our society. It's so ubiquitous that sometimes it's hard to see, honestly. But when you do, stand up to it. And then you also have the power to, in this particular audience, to actually enact policies that reflect that obesity is more than just willpower. It's not willpower. Willpower is someone who gets yelled at or made fun of walking down the street and gets back out there again to help their health and to get some more exercise. That's willpower. Willpower isn't trying diet after and not sticking to a diet. It's trying diet after diet after diet and not being able to overcome the hurdles because obesity is complex. And I hope you will, if you take nothing else away, that you gain a different view of people who have been exposed to weight bias and stigma their entire lives or even part of their lives and the damage it does. It's harmful, but we have the power to stop it.
Thank you all for that reminder about our shared humanity and how it will take everybody to move this forward. So to Patty and to Dr. Burke and Dr. Tamiyama and Dr. Crowley, thank you so much for sharing your experiences and your expertise. I am sure that you've given the people who have chosen to be here with us today a lot to think about and perhaps a lot to move on. So thank you for that. And I want to thank everyone who took the time to join us today to learn more about weight stigma and mental well-being and health disparities and policies to address parts of these intersections. We will, of course, be following up via email with the information that was presented today, and the recording of today's briefing and all the related materials that you saw will be available in the coming days on the reclaimyourwellness.org website. So thank you all again to our esteemed speakers and to everyone that joined us today. I invite you to have a great afternoon wherever you are. Dr. Tamiyama is holding on to those last minutes of the morning. So you have a great day as well. And remember, wherever you are, to reclaim your wellness.